Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back to the podcast. My name is Chuck Dowell. I'm here with Miles Gilbreth. We're excited to have Dr. Brooke Beckett. Dr. Beckett is an associate professor and director of the Residency Program at OHSU in Portland, Oregon. We know that podcasts and radiology don't necessarily mix, but we thought it would be excellent to have her on to discuss MSK Radiology and just the basic understanding of it. So welcome, Dr. Beckett.
Thank you very much. I really appreciate the invitation, and I'm super excited to talk with you all.
Disclaimer, she does have some PowerPoint slides, which if you're going to follow along on our YouTube channel, the video of the slides will all be on there. What are the things that you initially teach? You know, you're the director of the residency program there. You have, residents that come in learning radiology and the basics of it. What are kind of your initial steps as far as teaching somebody how to read an X-ray or an introduction to radiology?
Yeah, so that's a great question. Our residents are, rotating through all of the different services and different subsections or subspecialties of radiology. And so when they get to MSK, it can be a little bit overwhelming because it comes really back to like fundamental anatomy to begin with, right? So anatomy is key from your perspective too, translating the clinical anatomy and the physical exam, which we don't always have, but also translating that into kind of what you're seeing on the images. And it can be really challenging, especially when you're switching between modalities. When you're first starting to think about, learning to interpret radiographs, I think you just have to really, in my opinion, you really need to stay very thoughtful about your approach to each study and just start from just a ground floor basics, right? When you first start interpreting radiographs, like understanding the different radiographic densities, it sounds so simple, but it can be really challenging actually to learn and also just really fundamental to your understanding of how to interpret these studies. And then it's incredibly important from an MSK perspective to also familiarize yourself with the routine views. First of all, from an ordering perspective, understanding what best views to order regarding each bone and joint. And then really familiarizing yourself and really thinking about like, okay, what can I see on each of these views? What am I looking for? What do I think my, clinical diagnosis is? And does that sort of correlate with what I'm seeing on each of the views of the radiographs? Like, what is the common pathology to look for when my, shoulder is internal rotation versus external rotation, for instance. So just staying really fundamental and very structured in your approach, developing a search pattern, regardless of what type of imaging study you are looking at, is incredibly important. It's the most critical thing that we teach our residents, regardless of what type of study. And you must stay with that, make it a habit. Every single time you start looking at a study, develop your search pattern and stick with it. Doesn't really matter what it is, but just stick with it. Okay. And then the other tip I give people is practice what you struggle with most, right? It is human nature to avoid. I think a lot of us have to really work to overcome that. And whatever sort of type of study you find yourself struggling to understand the most, really dive in, right? So review cases, obviously, before you look at the radiology report. Familiarize yourself with those radiographic densities, the views, et cetera. What do I see in front of me and what information can I glean? If you have the ability, we always tell our residents to do this, and it is such a valuable tool. I'm not sure how it will work from the clinical perspective, but if you have the ability to search and patch for age-matched normals, especially in younger patients, right? So like search for, that 16-year-old pelvis. What does it look like? If you have a question about something that you're seeing, it can be really valuable to really understand what normal looks like, because sometimes that can be really the hardest thing when you start looking at these studies. And then of course, always, I'm going to put a plug in for your trusty radiologist. But if you have access to an MSK radiologist that you trust, absolutely reach out to them. We love to hear from our clinicians and really feel like we are adding value to your practice. So definitely reach out to us as well.
I think, you make a great point. The thing I teach students every time is
develop a pattern, right? I work in an orthopedic urgent care setting. I live in a world of x-rays. It's a fun day when I get to review an MRI, but I live in a world of
Yeah,
x-rays.
absolutely.
So I have them develop a pattern, and I think understanding standard views and which ones that you want is super important. I have the unique role of helping train our student rad techs in the after hours clinic.
Oh,
So I'm
lovely.
also giving feedback on positioning, over under exposure, things like that. And I do think one thing that I've noticed, I remember a situation where one of my surgeons got a shoulder, and by a student, it was completely overexposed. And it
Mhm.
looked like this supralytic humeral head. And so sometimes if you have a large concern like that, maybe go back and talk to your techs, right? Maybe say, hey, how was the exposure on this? Could you repeat this image before I order advanced imaging, just to kind of confirm what you're seeing? Just some things that kind of I thought about.
Oh, absolutely. That is so important, and we occasionally get, super overexposed or underexposed radiographs too. And, I find with our residents, in their first rotation with us, it's really difficult for them to perceive that. And they're just thinking about, like, okay, so why does this look funny? Or like, I thought there was something here, and actually, I just sort of have to have them step back and say, like, okay, so what do the soft tissues look like? I mean, they're really white, right? So this is like really underexposed. Or actually, like, where did the soft tissues go? Like, they're gone. I mean, this is super overexposed, and that's why the bones look so strange. And so, for the early learner, those different sort of technical issues can be really difficult to sort of perceive and, synthesize that information. But it's really incredibly important. Absolutely, absolutely, to understand what kind of goes into, on a very basic level, obtaining these radiographs and sort of how to tweak those for sure.
One thing you mentioned that I want to reiterate is clinical correlation. I know a lot of the times, ER, urgent care, Miles, myself, we've all kind of done it. We order x-rays, and we interpret our own x-rays at our clinic, but some clinics don't. Any information you can add to that x-ray as far as where the tenderness is at, I think helps the radiologist, right, zone in on the problem. Oftentimes I'll look at the x-ray before I go in the room. I'll examine the patient, and then I'll look in the x-ray again of where their symptoms are at. And, probably, a third of the time I'll pick something up subtle, after clinically correlating. And we'll get a lot of patients referred to us for like distal fibular avulsion fractures, and their pain's not even there. It's in the midfoot
Mhm.
area. And so I think clinical correlation is a huge thing that I didn't recognize as much when I was a young PA, that I think is helpful. So if you have a radiologist reading your X-rays in that box, if you can add patient complaining of pain over the second metatarsal, that helps the radiologist correlate to, hey, this is the spot I'm looking at. All these other incidental findings are not clinically relevant.
Oh, that's so important, Chuck. And I know everyone's really busy, right? But the vast majority of the radiographs that we receive are either like pain, trauma, like one word, right? That is, and that's fine. I mean, but it's really helpful when I get a two-word indication about, like, second metatarsal pain, or concern for stress fracture, or, and so it just sort of helps me hone my, like, look again. I will definitely look again. I also use, and you have the luxury, better than we do, but of using the soft tissues, right? Like, what's swollen? I mean, are you concerned about a Liz Frank injury? Like, and so I'll look for that midfoot, sort of swelling. And is if certain finger swollen? Is your wrist really swollen? And I didn't see a fracture at first. I will go back and look, because often we don't get that clinical information. We have to use all the information that we get. Even two or three words as to kind of what you're most worried about is extremely helpful. Yes, definitely.
Yeah, I think that's great advice for the hospital-based PA is put a real indication in there,
Yeah.
right? Tell them what you're looking for. And like I tell students is, the x-ray is 50, maybe 30% of their presentation. The patient completes it, right? You have to
Oh,
diagnose with your physical exam.
for sure. Absolutely. Absolutely.
Join us next week as we continue the discussion with Dr. Beckett talking about MSK Radiology. Join us at the National Conference for the PAs in Orthopedic Surgery. We will be at the Hilton San Diego Bayfront, August 31st through September 4th of 2026 this year. Registration is open now. You can find the registration at pos.org.